Welcome to HHS, and I'd like to stand for the pledge. And Senator Whitley, would you lead us in the pledge?
I pledge allegiance to the flag of the United States of America and to the republic for which stands one nation under God, indivisible, with liberty and justice for all.
Okay, I would like to open the hearing on a non-germane amendment, and that is 1371 relative to establishing a committee. No. Well, it's going to be attached to establishing a committee to study the New Hampshire Board of Medicine and making an appropriation to the Department of Health and Human Services. This is an amendment that I put together to help one of our nursing facilities in New Hampshire that has been struggling since they purchased that, I think in 2022. And Sean is here to speak on it, but I will go ahead and let Henry Lippman. Is he not here?
No.
Okay. Sorry, Henry. You need some time before you speak?
Love that attitude, Henry.
Not a problem.
Good morning. For the record, Henry Lippman, State Medicaid Director. This amendment, I think that New Hampshire's experienced record level of sales and turnover of nursing facilities. And within that group, there's a couple that have come in recently that didn't have the benefit of some of the funding that was available during the public health emergency and pandemic. And I think that flipping of nursing homes is not in the best interest of the residents or for the state ultimately. And one of the things that we want to work on subsequently is to, within the Department of Health and Human Services, is looking at how we're handling sales and things of nursing homes so that we create the right incentives, not the incentive to sort of pull money out of the state and increase costs, but to stabilize care and promote stability in that part of change in ownership. And what ends up happening in some instances that when a facility is acquired, it's acquired and has an extremely low rate, and that creates pressures on being able to serve people, and it also ultimately leads to structures that aren't necessarily, again, in the best interest when different components of the facility are created into different corporations, and the costs that get passed back through that creates exposure. Other states have experienced challenges in this area, and that's why I think this particular amendment's important in New Hampshire. Happy to take any questions.
Any questions from the committee? Seeing none. Thank you, Henry.
Thank you.
Sean? Welcome.
Morning.
Morning.
Just for the record, my name is Sean Stevenson. I am the owner of the operation for Pleasant Valley Nursing and Rehab Center in Derry, New Hampshire. I want to start with just first a quick thank you to Senator Birdsell for her amazing support. She took the time to come and visit the center, met with the staff, met the residents, took a tour, and was really engaged and really listened to our challenges. So thank you for that. I want to thank the whole group also for the support of the recent Medicaid increases that we receive starting January of 2024. Please know that it is definitely recognized and noticeable, and it really is making a difference in our ability to hire, to retain, and ultimately to really provide better quality of care. So thank you for that. Quickly, my background, I'm a lifelong New Hampshire resident. I was actually born and raised in Derry, New Hampshire, and this really should be a better story of what's happened with Pleasant Valley. There's a lot of positives, but it should be better. I have been operating long-term care centers in the state now for close to 27 years as a building administrator and multi-facility operator with other companies, and got into the ownership realm recently with Pleasant Valley. I actually should know quickly, I was also the Pleasant Valley's administrator in 1999 to 2002. So this really was a personal, emotional investment for me to really get Pleasant Valley where it is today. Pleasant Valley is a 112-bed center. As I said, it's in Derry. I'm just going to be completely transparent here. It was being operated by a company out of Atlanta, Georgia, that had at the time 90 facilities around the country. They didn't have any centers in New England except Pleasant Valley. Clearly, the center was not getting the needed attention, and frankly, it was being neglected by the operator, thus the landlord wanting to make a change. I became the tenant and the operator July 1st of 2022. Just to know, I now live in Bedford. I live only 20 minutes away from the building, and I am consistently on site supporting the center. When I took over the center had 40 empty beds out of 112. It had a 20-bed unit that was completely closed with the lights off and was used for storage. We had 25 full-time vacancies for nursing assistants, and we had 15 full-time vacancies for licensed nurses. What were the actions? So per my meet and greet with the hospital systems to let them know about the change of owner and my investment in the building, hospitals such as Catholic Medical Center, Elliott, Parkland, St. Joe's, Southern New Hampshire, all requested and asked if we could start to take more admissions and to reopen that closed unit. We started immediately ramping up staff in order to accomplish this, which was at a premium cost of adding contract labor staff, but also I went in and improved our hiring wage grid. That was a must. It hadn't been updated in years. We had to start doing referral bonuses, sign-on bonuses, and even extra shift bonuses to get folks to work and help in the care delivery. Where we are now, the center now only has 8 to 10 empty beds. It was previously 40. We have no more vacancies for licensed nursing assistants. We're contract labor free. And we have now only 5 full-time vacancies for licensed nurses. I turned over 75% of the leadership team to improve it and get folks on the bus to where we want to be. All that is at a cost. I'm proud to say now that we now employ almost 100 people in the center, and we take care of consistently now about 100 patients. 70 of those 100 are New Hampshire Medicaid recipients. We accomplished all this in 18 months. Finally, just to wrap up on the financial challenges, from the very first day, we were bound by cost reports that the previous operator had submitted, including cost reports that, when we did more research, had mistakes on it. It just supported the previous operator's lack of attention and engagement to the center. The center averages, as I previously stated, now 70 New Hampshire Medicaid recipients, which is 70% of our total population. Prior to the January 2024 increase, which I thank you for again, Pleasant Valley and Derry had the second lowest Medicaid rate in the state, in the entire state. And I think it should be noted that Derry is in southern New Hampshire. It's 20 minutes away from Massachusetts, so we are competing as far as workforce with that cost. And we're competing with Manchester, Nashua, and even the Seacoast region for workforce. Can't have the second lowest Medicaid rate in the state. The state was paying us an average at the time for the last 18 months prior to January, $195 a day per resident. Our costs to do everything that I just said was $322 a day. You can do the math on that. So including the cost to reopen the closed unit and the rate not covering anywhere near our cost to do what we had to do, we were, even if we were at the average, we were underfunded in the 18 months by close to $1.5 million. Because of our underfunding, the center has had to operate with negative cash flow. As many know, I had to go in to start the business, had to take out a line of credit. I since then subsequently have had to go back to lenders time over time to where now my loans have totaled over $1.2 million. I've had to hold off paying vendors for sometimes months at a time, having to take calls and explain my situation. I've had to sweat out multiple payrolls for all the staff I just explained that I hired, had to sweat out monthly rent payments. I've even had to sweat out this quarterly provider tax payment to the state, which has been an average of about $140,000 a quarter. Wrapping up here, again, while 2024 looks much more promising and I'm very grateful, we are still underwater overall due to what happened for half of 2022 and all of 2023. Thank you. Any questions?
Thank you, Sean. Any questions from the committee? Seeing none. Thank you.
Thank you.
Is there anyone here that would like to speak on the amendment that has not been given the opportunity? With that, I will close the hearing on amendment 1371. Thank you.
Takes a bit.
Yes, it does. I don't know. I know he's in a meeting. Should we hold off until? Okay, so we'll hold off executing until Senator Bradley gets back from his meeting. So with that, 9:15. It's almost on time. Why don't I open the hearing on House Bill 1028 and invite the prime sponsor. Representative, welcome.
Good morning, Chair Edsel and committee. Representative J.D. Bernardi, Rockingham 36, Hampton Falls, Kensington, Southampton, Newton, and Plastow. The amended analysis of this bill is largely correct. I just want to make the key point. The purpose of the bill is for patients with intellectual disability, so put them in a position so they would not be denied mental health services because of their intellectual disability, which was the case as the statute currently exists. This bill was submitted by me, but with the substantial help of Ann Seneca, who's here also to testify. We are both board members of One Sky Community Services, one of the 10 area agencies that supports developmental disability and acquired brain disorder community. Anne is also a mother with a son who is impacted by the current law and is therefore seeking this change. It is a small change to the law, but will have significant benefit for a small population. She can answer the technical questions far better than I can, so I will yield my time to that, but willing to answer any questions that you have right now.
Any questions from the committee? Seeing none. Thank you, Representative.
Thank you.
Thank
Jenny
you.
O'Hagan? Oh, I'm sorry.
I think he referenced me, so I thought I was to come up next. since
Okay.
I introduced the bill. Thank you so much. My name is Ann Sonic. I live in Exeter, New Hampshire. And as Representative Bernardi said, I put forth this bill. And it's a very interesting bill and a very interesting problem that is unique to a relatively small, segment of the population, and relates to people with intellectual disabilities. And HB 1028, did get wordsmithed by the House. Originally, I wanted to extract the phrase intellectual disabilities out of the statute. There's a clause in the provision of RSA 135 which excludes intellectual people from, and disabled people from mental health services, really shockingly, if it's perceived as the primary cause of their emotional or behavioral or mental health services. So this bill fundamentally seeks to end discrimination against persons with intellectual disabilities and improve, and this is really the important part, because again, shockingly to me, the mental health system is opposing this. This is designed to really improve the delivery of mental health services in the state of New Hampshire. Switching out that word primarily responsible to solely will allow those, we hope, those with intellectual disabilities to be entitled to the rights and benefits of other New Hampshire citizens when it comes to accessing mental health treatment and expertise. The exclusionary language of 135 C2 has really been hugely detrimental on individuals with intellectual disabilities and their families, and certainly the taxpayers of New Hampshire, because these are the people that are often stuck in the ER for weeks or months at a time. With an ER staff that's ill-equipped to deal with the problem. We have state hospitals who refuse to admit them despite actually having all the resources to do so. This person is trapped in the ER or at home, while the Bureau of Developmental Services often is forced to place these people after a long stay, anywhere from 14 days to 30 days. My son was in the ER in Exeter for 28 days in the ER and under fluorescent lights on a transport hospital cot and chained to his bed for the first couple of days. An intellectually disabled person who has the cognition of a 7-year-old who still misses their mommy and listens to SpongeBob is chained up in New Hampshire hospitals because the state mental health people are going, we don't know how to do this, we can't help you. And so these people, what happens the state do? They send them out of state after they get stabilized, because then ultimately they're put on psychiatric medication. They're stabilized, or if they're not, they're sent out of state. Texas, Florida, Pennsylvania, Massachusetts. That's where about 60 to 70 people with intellectual disabilities from New Hampshire are sent right now. And often it started in the ER. As I stated in my testimony before the House in February 14th, I've been dealing with this for many, many years. I've been involved in the field of developmental disabilities through no choice of my own, but because that's the cards that were dealt. I've been on the board of directors for different agencies related to this population. Like I said, I live in Exeter and I currently teach business law at Southern New Hampshire University. And looking at the statute, after my son had this issue about 6 years ago, when he was first hospitalized at the ER in New Hampshire. It was on the news and all that. I still get calls every couple months from parents in the exact same situation. Just a few months ago, somebody was stuck in Elliott Hospital, couldn't get treatment. The state hospital wouldn't take them because they were autistic. They don't even use the word intellectual disability. They were autistic. Didn't want to take them. The Bureau of Developmental Services didn't have help. These people are out of their minds in grief, fear, and helplessness. When my son was in the ER, even the ER doctor called me at home, hunted me down. He's like, how come they're not taking them? What are we going to do? You got to call the governor's office. They don't understand it. No one will help. Parents are told time and time again the person is not entitled to mental health services on grounds that their person has an intellectual disability. He's mentally retarded, or he's autistic, or he has Down syndromes. This is contrary to the very purpose and policies of the New Hampshire Mental Health Statute 135. It's very broad in its scope and aspiration. Yet folks with intellectual disability are routinely excluded from care. Yes, sometimes they do get care at the mental health agencies. If anything, that should go to prove the fact that they're absolutely qualified, because a lot of times you'll hear mental health, especially psychiatrists, interestingly, are seemingly often the most afraid, I found, from personal experience. They're like, I don't get this, I don't know what this is, I prescribe. I treat soccer moms with depression or people with extreme schizophrenia. I don't know what this is. Whereas, other people a little bit lower down the tier, they end up prescribing them the drugs. They can figure it out. It's not that complicated. And the mental health statute specifically allows for the treatment that the mental health system in New Hampshire is supposed to establish, maintain, and coordinate, keyword, comprehensive and effective and efficient system for services for people with mental illness. Why not people with intellectual disabilities? They're just as subject to short-term or moderately, a little bit longer bouts of psychotic break, mood disorders, anxiety, depression. All that can be treated, not only with medication, but very typical behavior modification type procedures and modalities that psychiatric units, that mental health institutions do all the time with typical people or normal people. So that's why we're moving for the statute to be changed, so that these mental health institutions can't go, well, it's primarily caused by intellectual disability. There's no, oftentimes why these people end up in the ER is that they suddenly are getting very aggressive, or they're saying things that don't make sense, or they're not communicating in a way that the caregiver or family has seen before. And many times there's no documentation of this atypical behavior in the medical records or school records or other records. And so that's why they bring them to the ER. It's not typical. It's not ordinary behavior for an intellectually disabled person. And yet the Mental Health Institute organization like Concord Hospital State Hospital will say no. They're autistic. That's what's going on here, and that's not the case. So we want to remove the word primarily caused by and put solely, because it's very unusual. It does happen that somebody with an intellectual disability is so severely disabled that they have very maladaptive behaviors that may be exclusively related to their intellectual disability, but more likely not. And you can clearly see that from the pattern of treatment. And a doctor any doctor, psychiatrist or otherwise, has to look at a whole picture comprehensively and determine whether something is mental illness or attributed to maybe a health issue. And so they would still have that obligation and still have that right to do that. This doesn't limit them at all. And my other argument I'd like to make is that, to point out to you that many individuals with intellectual disabilities do have a complicated picture and do require a multidisciplinary approach. And you'll see that I was just given a letter before we came in by the Community Behavioral Health Association, which acknowledges that. But I'm surprised, I'm stunned, honestly, that the mental health system and agencies would say, yes, they require a multidisciplinary approach, but, we don't want to be at that table. No, we need more cooks in the kitchen on this one, not fewer. The mental health people are actually the ones who diagnose and prescribe medication. Mental health facilities are equipped with staff that understand restraint, that understand de-escalation, and they understand medication. The ER does not. And just a basic residential program does not. If somebody's kind of going off the rails, that's the place that does it. I've represented people in the state of Massachusetts. I've been in psychiatric facilities with very extremely disabled people. They're often in there anywhere from a week to 2 weeks. The goal of modern psychiatric medicine is to let's get this person stabilized. If we have to do it through medication, yes, to get them to a baseline, and then we try to institute certain behavior modalities and treatments. It's exactly the same way of going about things with a person with intellectual disabilities, 100%. And so it's shocking to me that a medical professional from the mental health would come in and say, oh, we don't get this, we don't know this. I have a psychiatric degree from, I don't know, Harvard or wherever, and I don't know how to do this. That's insane. I'll come tell you, come sit with me and I'll help you out. It's not that complicated. Last year, a district court judge ordered New Hampshire, as you know, to end ER boarding for psychiatric patients as of May 2024. I think that got extended to 2025. I'm very concerned that intellectual disabled people are not factored into this equation. When you look at the wording of the statute, they'll continue to suffer, and so will the ER departments. The hospitals and state are going to have a big problem on their hands. The judge declared that the state can only hold people in emergency rooms for up to 6 hours if they're there for a psychiatric admit before transferring them to another facility for treatment. This demographic also needs to be accommodated and given a place to stay when in the throes of a mental illness. Why are we discriminating against them? This can't be resolved by the mantra, it's not my department, next window. Everyone cannot stay on their own lane in this language. There needs to be a conduit between these agencies, and everyone will say it. I read some of the lit, oh yeah, we all need to talk, we all need to get together. Well, it's not happening. So we need to open the door legally and say, you the mental health organizations, you these things, you have to figure it out. It's not that complicated. You've got everybody in place. You have access to the Bureau of Developmental Services. You have access to the schools. You are now in the mix. You are absolutely in the mix, and you work with those people to resolve this situation. We don't want to continue pushing this population aside who's historically been pushed aside. When you think about the educational system, it used to be that somebody with intellectual disability, the schools didn't take them. Well, you're something wrong with your brain. We don't educate you. Well, that's changed, right? Now we have schools, we have mainstreaming, and we have mainstreaming as well as special ed and alternative programs. The school systems are now these people can be educated. They can learn, they can grow, they can get jobs. It's the exact same scenario. They can be medicated, they can be stabilized, they can be benefited from mental health treatment. Don't shut the door on them for this. And we're not talking about a lot of people here that actually require psychiatric treatment. It's really just a handful, probably from 10 to 15 a year end up in the ER in New Hampshire, but they're stuck in there for weeks and months. My son total was almost 60 days. At two different places. They could have gone to a psychiatric hospital and had some treatment. And if the psychiatric hospital thinks, well, we don't know what to do, like I said, it's not that complicated. Hire somebody to come in and do a consulting, some professional development. Believe me, you'll get on speed pretty fast. The other point I want to make to you is that on a little more serious note, is that I really feel that the clause is discriminatory on its face. The use of any exclusion, I really feel the inclusion of the intellectual disabilities is discriminatory. But certainly saying that if it's primarily caused by that, that's making a presumption, a legal presumption that a person walking in the door with an intellectual disability it's presumed your behaviors are due to that. Why? Why are you making that presumption? When you think about teenagers, all right, we know teenagers, they shut themselves in their room. They don't want to talk to anyone. They get emotional. They're moody. They cry. There's a high incidence of suicide rates. Does the mental health profession go, well, they're just a teenager. That's the nature of a teenager. They get depressed. We're not going to see them. We're not going to treat them. No. It's the same thing with intellectual disabilities. They have the same type of symptomology, comes and goes, waxes and wanes. They grow out of things. My son did. He had some incidences for sure, seemed to be a psychotic break. I've never seen anything like it. Ultimately, he was put on antipsychotics, mood stabilizers, received like therapeutic counseling or occupational therapy, and he's stabilized and he's able to function and go out in the community now, just like many people who have, typical people who have those issues. But you know, to leave this in, I think really exposes the state in many ways. The Equal Protection Clause of the United States of the 14th Amendment requires that similarly situated individuals should be treated similarly. Someone's coming in being uncharacteristically irrational, not having a sense of reality, showing very unusual maladaptive behaviors. Every parent will tell you that who's gone to the ER. That's why they're there. This isn't normal life for us, and that's why we're there. But unlike other people, typical people who go and show often even more extreme behaviors, they get admitted to the psychiatric hospitals. And I would say this also constitutes a violation of the Bureau of Developmental Services statute, Chapter 171A, where it says that these vulnerable individuals, that under the statute, the Human Services has failed in its duty to establish, maintain, implement, and coordinate a comprehensive service delivery system. That's what they're supposed to do. That's what it says in the statute. Both those statutes, if you look at the language and the mission and purpose of them, the mental health statute or the Bureau of Developmental Services statute, they both have the same obligation to provide comprehensive, efficient, and effective services. And this is a huge gap. It's not being addressed. And again, the psychiatric side is going, we don't understand this. That's astounding to me that you say you don't understand this. Then maybe you should close shop, because this is exactly what you do. All right, well, I'm going to close on that. I've talked a long time. If you have any more questions, I'll be happy to answer it. But I really would encourage you to strongly consider, supporting the amended language. Removing it will definitely motivate the mental health organizations, the Bureau of Developmental Services, and the area agencies to work together to address this gap in the system and end discriminatory allocation of mental health services. We don't need a committee. We don't need a study. There isn't going to be a big cost associated with. We're talking, an extra bed, having some consults on staff, which mental health organizations are constantly bringing in consults on this or that. You can hire a consultant to help you. You can get somebody trained in working with people with developmental disabilities. Maine has Spring Hill has a unit. Hampstead had a unit for intellectual disabilities. There's resources to go figure it out. And I think if you have a medical degree, or any type of advanced degree in mental health related services, I believe you can handle it. So I would ask you to support the bill. Thank you for your time.
Thank you, Anne.
I have a brief question, just kind of a yes or no, but if that's okay. The way I'm understanding what you just said is that if I go into a place and I'm having a mental illness situation, I'm treated. But if I have Down syndrome and I go and I have a mental breakdown of some sort, I'm being discriminated against.
Just-
This bill fixes that.
I don't know if it'll 100% fix it, but yes, I think it will improve the likelihood that that person will get treatment.
Thank you.
And like I said, that medical doctor still has discretion. I mean, they still could go, I think it's solely cause, but there has to be some documentation to support that. They can't just go, intellectually disabled.
Thank you.
Thank you. Any other questions?
Any questions from the committee? See you
All
next.
right, thank you.
Thank you, Ann. Jenny O'Higgins.
Delay just for about 5 minutes.
Sure. Lisa Bodwin.
Good morning. For the record, Lisa Bodwin. I have to say that I am profoundly puzzled by the opposition to this bill. I came in this morning simply to sign in, only to find out that there is opposition, organized opposition to this bill. It's confounding. So I appreciate your patience with my sentiments. I would like to say first that denying people with disabilities the right to access behavioral health services is a violation of the Americans with Disabilities Act. I think Karen Rosenberg is going to speak to that a bit more. And if the department comes out in opposition to this bill and it passes, I think it would put the department at risk for a lawsuit under ADA. The siloing of services harms the ability of people with disabilities to be contributing citizens, because if they don't receive these services, they can't be in the middle of America getting jobs, volunteering, participating in their communities. I would also like to point out that opposition to this correction and omission is violently ableist. The gross misperception that an individual with an intellectual or developmental disability can't have feelings and experiences that require the benefits of behavioral health services is yet more evidence of how structural ableism dehumanizes people with disabilities. The service provider system, our area agencies, are not in a position to provide grief counseling or situational depression services. That's not what they do. I would also like to point out a quick fact that people with disabilities are 3 to 6 times more likely to experience abuse, neglect, or exploitation, and severe trauma over the course of their lives. And this is not something that the service provider system can fix. You need behavioral health services if you have been traumatized and have PTSD, as just one quick example. As Ms. Senek said, not all of a person's behavior can be solely attributed to their disability status. People with disabilities are not one-dimensional. They are not solely their disability. They are whole human beings with lives, preferences, desires, dislikes, etc. My son, Forrest, lost his father very unexpectedly a few years ago. Forrest is a person with trisomy 21. You call this Down syndrome. He was grief-stricken. Nobody in his area agency was going to be able to help with that. If he had not received grief counseling, he would have ended up with a severe depression. And under the current statute, Forrest would be precluded from getting the services that he needs. Disability is one thread in the weave of a person's life. Whole person care is the legal, moral, and ethical right owed to people with disabilities. They are human beings first before they are a person with a disability. Thank you.
Thank you. Any other questions? All right, 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 thank you. Any other questions
Thank you, Lisa. Any questions from the committee? Seeing none. Maggie Pritchard.
Good morning. Thank you very much. My name is Maggie Pritchard. I am the president of the Behavioral Health Association, which is the 10 community mental health centers in New Hampshire. I'm also the CEO and president of Lakes Region Mental Health Center. Just as an aside, 42 years ago this week, I was in a snowstorm going to my first day on the job at Manchester Mental Health, where in fact we had a program for people with intellectual and developmental disabilities, and they still do. We had about 42 patients from the Moore Center who would come for medication services and group therapy. I work at a mental health center where we have specialty care and have a team that serves people with neurocognitive disabilities, including those with intellectual and developmental disabilities. All of the mental health centers are required in their contract to sign an agreement with the developmental service agencies, the area agencies, to work with shared clients who they can comprehensively treat. I wish that this bill could fix everything. I really do. At 15 years old, I went to the Laconia State School. I'm pretty sure that's why I'm a social worker today, is that influenced my need and desire to help people who were institutionalized and not getting the right level of care that they needed. I don't think that this bill fixes anything. I think what it does is it brings about an important conversation that we need to have about two siloed systems that need to work better together and need a comprehensive plan for how we can care for people like this lady's, Miss Seneca, that we can have a unit in the hospital dedicated to people with developmental disabilities. We had that at one time. New Hampshire Hospital had a unit called I-Unit. There was a neuropsychiatrist that was there. People were cared for. I think that what we haven't done as a system is challenge ourselves to fix this problem together. There's no fiscal note on this legislation, and I would tell you that there should be, because you can't fix it without having the expertise and the facility and the people to provide the care. I have doctors that work for me. Yep, they went to med school, but they are not willing to deliver a baby, right? They're psychiatrists. And sometimes when we have people who need specialized care, we don't have that in our system. I have a lovely, lovely therapist who loves to work with people with Down syndrome who have adjustment disorders and need short-term treatment for grief counseling. We do our best. All of the mental health centers have programs. As a matter of fact, the testimony that was given previously at the House level by some of the members of the staff at mental health centers shows how passionate we are about doing this work and being able to serve people. But this legislation is not a magic wand, and it is not going to fix the inherent problem of a system that doesn't have the specialized care and the services that are required for people who have what's been described previously. I would say that for us, we are more than willing to engage with the commissioner and the Department of Developmental Services to come up with a solution, but this just falls short. And I thank the representative for bringing it to everyone's attention because it's an important conversation. But this legislation doesn't really do what you want it to do. Do you have any questions?
Any questions from you?
Yeah. So basically what I'm hearing you say is that if somebody has, say, Down syndrome, they're definitely treated differently than somebody who doesn't have it. And if they're having an emotional breakdown, it almost sounds like they're being discriminated against.
No, so if you had Down syndrome and you came to the mental health center and your father had passed away and you needed short-term grief counseling, we would give that to you, right? We would give it to you through our outpatient counseling department. We wouldn't give it through state services because state services are well-defined in statute for long-term care, right? So you have two systems that have existed in two silos for a very, very long time. And they cross well together when they agree on treatment. When there are exceptions to that, the patients who need specialized care, who need more intensive care, that's a systems issue that we don't have a solution for. We don't have a psychiatric unit. I don't even know that we've engaged in a conversation with the Elliott, with the new psych hospital, to say, can you put in a unit for intellectual disabilities and people with developmental disabilities? I don't think we've had that conversation at all. Should we? Absolutely. But I don't think this legislation fixes anything. And that's why we oppose it, and because it has no fiscal note and there is a cost.
Yeah, just a quick follow-up. So we heard that, up to, 28 days in the emergency room. I mean, what's the solution? How do we go about fixing that if not this?
So I had a child in the in Lakes Region General Hospital last week, Concord Hospital, and he was there for 30 days, and he had to be sent, as was described, to Arkansas for long-term care, because New Hampshire doesn't have the long-term care that this child, who has complicated issues, mental health, autism, what have you, and he went to Arkansas because we do not have a bed for him here, and he spent 30 days at the hospital with people coming together. The Bureau of DCYF came, the Mental Health Center came, the hospital staff came, and we couldn't fix it. It's a problem.
Any other questions from the committee? Seeing none?
Thank you very much.
Thank you, Meg. Karen Rosenberg?
Just need a minute. Good morning. My name is Karen Rosenberg. I'm the policy director at the Disability Rights Center, and I'm here in strong support for HB 1028. HB 1028 is an anti-discrimination bill. If passed, it would ensure that individuals who experience mental illness and are otherwise qualified to receive services from the state's mental health system would not be denied those services because they also experience an intellectual or developmental disability. Under current law, mental health providers in the state system may deny services to individuals who would otherwise qualify for mental health services based on the assertion that their functional impairments they are experiencing are primarily caused by their intellectual disability. This language perpetuates an unwarranted and false assumption that individuals with disabilities like Down syndrome or autism or other developmental disabilities cannot benefit from mental health treatment. In addition, this language, when relied upon to deny mental health services to otherwise qualified individuals with intellectual disabilities, likely violates their rights to equal access to government services or public accommodations under Titles 2 and 3 of the Americans with Disabilities Act, or ADA. 1028, if passed, would put an end to this discriminatory practice. Now, you've heard testimony that the community mental health centers are already providing services to people with co-occurring illnesses, so apparently they do have the ability to do this. But this law, as our current law provides, allows entities, government entities, and community mental health agencies to deny services to individuals who experience an intellectual disability without requiring any formal assessments, just by their simple assertion that they should receive services through area agencies. They have an intellectual disability, they're not our problem. And this has come up in our office. It doesn't come up every day, but 1 or 2 times a year, we get complaints from people who experience both an intellectual disability and a mental health impairment who are denied services from their community mental health agencies. And as you heard from the Community Behavioral Health Association, the idea that we would treat people with co-occurring conditions is nothing new. There was a clinic 42 years ago, the day she started, in Manchester Mental Health Center. We know that there have been efforts and discussions for years at the state level on this. And I think it's important to realize that this is nothing we need to study. It has been studied. I distributed some testimony for you to read that was provided by a clinician who testified at the House Health, Human Services, and Elderly Affairs Committee meeting on this very bill. And I want to highlight some of that testimony for you. The testimony was provided by a woman named Julie Lego, who is a clinical social worker with over 24 years of experience. And she is actually a person who works although she testified on her personal time, she is a clinician at CLM, Center for Life Management, that has a dual diagnosis collaborative program where they provide integrated care for people who experience developmental disabilities and intellectual disabilities, and they coordinate with their area agency. One thing I know from personal experience and also from her testimony is that she receives calls every month from people from different catchment areas who are not able to secure services based on this notion that their primary diagnosis of intellectual disability would preclude them from receiving mental health services or securing a diagnosis. I know this because I referred someone to her from a different catchment area about a month or so ago. Another thing that Ms. Lego talked about was that the functional manifestations of someone's disability can change. It can be sometimes based primarily because of their mental health impairment. Sometimes the manifestation can be based on an intellectual or developmental disability, and those things can switch over time. And so by having a law that says, well, it has to be primarily due to not due to autism or another intellectual disability to qualify for services, we are basically taking a swath of people, not a big swath, but people who experience both, out of the ability to get services they need for a real medical problem. One of the terms that Ms. Lego used that I needed to look up is the term diagnostic overshadowing. And what she said, and I'll tell you what that means, but she said that the primary cause of mental health symptoms and functional impairments changes based on the presenting needs and exacerbating systems. It is imperative that the reference to primary diagnosis be amended to support equality in access to mental health assessments and services for all, and to seek to prevent current practices of diagnostic overshadowing within current language used in reference to primarily caused by. Well, that is a lot of words. So I did a little bit of research, and according to the Encyclopedia of Autism Spectrum Disorders, this term, diagnostic overshadowing, is defined as follows. It is a negative bias impacting a clinician's judgment regarding co-occurring disorders in individuals who have intellectual or other mental illness. And what research indicates, and I found this by really spending like 15 minutes, like looking at PubMed and various other publications, and I can send you some articles if you'd like. It indicates that diagnostic overshadowing leads to compromised patient care, likely contributes to increased mortality experienced by individuals with mental illness. If you are interested, I can forward you the link to the YouTube video where various clinicians spoke about treating people with co-occurring conditions, with the place where you will find it, so you don't have to look through 6 hours of video. And as far as training and capacity, this is not brain surgery. This is something that has been discussed. There are trainings available. CLM, which I referenced to you, as I've become aware that as far as part of this continuing of collaborative care model they've already developed training and have a certificate program ready to go for people on how to treat people with co-occurring illnesses. A couple of years ago, they actually offered this training, a 3-day module, to everyone in the state. Well, every mental health provider in the state. So they are ready to go. If this is if this is where we are headed. And what current law requires, 135C13, is that if there's a funding need, then what 135.13C13 requires is for the mental health centers to let the department know that they need more resources, and then the department, it's incumbent upon them to use that information for their budget planning purposes for the next budget. So we've had this mechanism in place for years. We know there are people to be consulted with. We know that mental health providers already have, who are licensed, have CEU requirements. They could be using these training opportunities to fulfill those requirements so that they can no longer discriminate. And we need this change in the law to provide the fire that's needed to make this actually happen so that people aren't inadvertently or purposely denied services they require. I'm happy to take any questions.
Thank you, Karen. Any- Senator?
Thank you, Senator. And thank you for your testimony. Basically, I'm reading a testimony from the Greater National Mental Health, and the CEO basically sent us some testimony. And she basically said that this would create a new program. There's no fiscal note, fiscal staffing, and redundancy and duplication of cost. Do you agree with that?
I do not agree with that. Like I said, I think these are community mental health centers, and our mental health services system must serve all otherwise qualified individuals. And so if an individual has a mental health impairment that, would qualify them for mental health services, it would violate their rights under the Americans with Disabilities Act to deny them access to those services. So they are already required to serve these folks. They're just, at sometimes refusing to do it.
May I?
Follow up?
I'm afraid. So what, if I heard you correctly, then the institutions are required to say, look, we need funding, and they need that from the department.
I'm sorry, can you repeat that?
So these organizations need to tell HHS that
Yes.
we need the funding, and so the onus is on them if they do not ask for that.
They need to ask, under our state law, they would need to report the need for additional funds to HHS, and then the department, it's 135C13, which has this obligation. So this is actually a non-discrimination portion of our state law, and it provides, if necessary services are not available, each agency responsible for provision of such services shall notify the department of the need for them, and the department shall utilize such information for budget planning purposes. So yeah, this is like, this has been in the law for quite some time. And we do have, as I understand it, some uncommitted ARPA funds still available at DHHS, unobligated funds. So if DHHS so chose, they could use some of those funds to get this certification program off the ground that CLM is ready to start as soon as they get the go-ahead.
Thank you. I'm just going to, Karen, I'm going to follow up on Senator Avard's line of questioning and thinking. So what you're saying is that these services, say, clinically are available in these locations, but there's the funding piece of it that comes from DHHS that once there's a diagnosis made that would hold back this funding?
No, definitely not. I mean,
It's not a criticism. I'm just trying to
Yeah.
figure out, it sounds like you're describing a bucket and we're not able to pull the bucket over because the way the law is written to provide those services.
well, no, I don't think so. I think the services are already required, that they are already required to provide these services under our federal law, under the ADA. And because this is a governmental program, and so for otherwise qualified people, they're required. I've heard testimony that I know, it is no secret that our community mental health system needs more funding. We know that there are the impact, for example, of the Medicaid unwind, the elimination of the protections from Medicaid disenrollment, are over, that the mental health centers are suffering. There is no doubt. And there is no doubt, I know that they are going to be receiving Medicaid rate increases. That ought to help, but certainly our mental health system needs more funding. This is not a bill that fixes everything. And this is something that I can agree with Maggie Pritchard on. It doesn't fix everything, but what it does do is say that you can't use the, concerns about funding to deny services to people who are otherwise eligible based on their disability.
All right, I think we're saying the same thing. Follow-up, thank
Oh,
you.
sorry.
Yeah, essentially we're saying the same thing, but I'm taking it off of the requirement piece and just stepping back and saying co-located clinical capabilities are there, and and your position is they're required. I'm not denying that, but that they're not provided because a certain diagnosis is put down and it makes another bucket unavailable, required or not. That's, I think.
Yeah. Okay, maybe I misunderstood
Yeah,
you.
no, I actually was drawing these little silos,
Yeah.
trying to lie. So we're on the same page?
Yeah.
Okay, thank you.
Okay, thank you. Sorry, I didn't understand your
No,
inquiry.
it's all right.
I mean, it's complicated, but not that complicated, right?
Any other questions from the committee? Seeing none, thank you, Karen.
Thank you for your time.
Oh, here's my pictures and my pen.
So, Jenny? So do I have Dr. Charette here? Charette?
Yeah.
Okay. So we got 2 for 1?
We do.
Okay.
So-
Welcome.
Hello there. I'm Jenny O'Higgins. I'm a senior policy analyst in behavioral health for DHHS, and I'm joined here with.
I'm Cynthia Bobonis. I'm a licensed clinical social worker and the director of social work at New Hampshire Hospital. I've worked at New Hampshire Hospital for 24 years.
And I'm Dr. Samantha Sweater. I'm the associate medical director at New Hampshire Hospital.
Good morning, Chairwoman Birdsell and honorable committee members. I'm here because I do have concerns about HB 1028 with the way that it's worded. Currently, New Hampshire Hospital does serve dually diagnosed folks with developmental disability and mental illness. At any given time, we have 10 to 15, sometimes more individuals who are dually diagnosed, and we always have. So there is nothing that prevents us from providing inpatient acute emergency psychiatric treatment to people who have a mental illness and an intellectual disability. I've worked at New Hampshire long enough to remember when we had a unit that we referred to as the neuropsych unit. It was a specialty unit. I think that we provided really good care in that unit, but one of our biggest challenges reflects some of the gaps in care that have been testified to already. Because folks would come in and we would stabilize their psychiatric symptoms, but then they would remain in the institution for extended periods of time while we were looking for the appropriate lower level of care to discharge them to. And that's part of the reason we don't have it anymore. I think that the statute as written was written that way to protect against institutionalizing individuals. And so we have to be very thoughtful about what can be treated in the most acute and secure setting in the state. And be thoughtful about making sure that someone's dangerousness is due to a condition that we can treat in that setting. It's not about whether or not they have a co-occurring intellectual disability. It's about, do they require that level of care? There are people with mental illness that we wouldn't treat at New Hampshire Hospital either because they don't require that restrictive level of care. And that level of care is not necessarily necessary to make them safe. As written, the other concern I have about HB 1028 is that I believe that it leaves the door open to admit people not just with intellectual disability, but also individuals with substance use disorder and potentially even intoxication to be involuntarily committed to New Hampshire Hospital. While the word is solely, what that means is that somebody could primarily be admitted for dangerousness due to substance use disorder and intellectual disability. Mental health diagnoses include things like adjustment disorder, with depressed mood, anxiety disorder, conditions that a large proportion of our general population who are high functioning and do not require hospitalization are diagnosed with. And so I think that we need to take that into consideration in terms of the wording of this bill. Thank you.
Good morning. So I was just going to give a little bit more information about the clinical distinction between mental illness and intellectual disability and what the treatment looks like for those two populations. So everyone with a behavioral or emotional disturbance of any kind deserves access to high quality care and comprehensive care. The difference in psychiatric training, what we get trained to do is use medications that work on circuits and neurotransmitters in our brain that help change those circuits so that the circuits can function differently in a better, more helpful way for that person to have less disability. And for intellectual disability, the treatment, it is more therapy-based and more behavioral-based. In terms of behavioral management techniques, we don't get any training on that. That is not standard. It is available, but you have to go seek it out. And that's true, I think, it's certainly true for any psychiatric practice. And the team, while medications sometimes can be a part of managing people that have challenging behaviors, they aren't a fundamental part of it. There's actually a lot of new studies that are coming out that are showing that not only are the medications that people are prescribing for those with intellectual disabilities are not evidence-based, they have a lot of side effects too. So there's been a lot of prescribing practices and tools that have been created to help de-prescribe in that population. And I think it's important to distinguish that people with intellectual disabilities can have challenging behaviors that are a result of the intellectual disability itself. But there are people that have a co-occurring illness. So I think the most common thing that we see is co-occurring PTSD or schizophrenia, which can happen in that patient population as well. And those people can also have challenging behaviors. And those are the people that we currently treat at New Hampshire Hospital. So those are the people that come in and we work with them on medications to help stabilize their PTSD or schizophrenia. For the intellectual disability part, if there's challenging behaviors that arise because of that, then it's a comprehensive team of people that involves occupational therapy, a behavioral analyst that we don't have at New Hampshire Hospital. We currently don't have a behavioral analyst. Sometimes it can involve speech therapy, physical therapy. It's a whole team of people. Like if you think about an IEP, like that's the similar team of people that you get. And we don't have a team of people that specialize in that at New Hampshire Hospital right now. And to Cindy's point, currently we have 13 people at New Hampshire Hospital that have a mental illness and a co-occurring intellectual disability, and that does not include people who have autism. So people who have autism would be in addition to that. So we have 13 people with intellectual disability and even more that have autism and a co-occurring mental illness. We do recognize the need for treatment of this patient population when they have severe challenging behaviors, but the complexity of the problem necessitates a comprehensive solution and one that does not oversimplify all of this and try and put patients into a system of care that may not be helpful because we don't have, or as right now, we don't have the resources at New Hampshire Hospital to take care of this patient population. And it's difficult for these patients. So not only is there not a tremendous benefit because we don't have the specialized team to treat them, it's hard. I think people think about New Hampshire hospitals, when people go there, they get better, they get discharged. And there are risks to coming to our hospital. It's a place where people go who are severely mentally ill. And it is hard to be on those units, especially for someone who is intellectually disabled and doesn't understand what they're seeing, which I've seen multiple times. Have people come in, and it's really hard for them to try and make sense of what they're seeing. And sometimes they can pick up new maladaptive behaviors that they didn't have before. And so it's not only is sometimes there's not as much benefit as we would like, there are risks to it also, which I think should be considered.
I just want to clarify one thing that Dr. Sweater is saying. We do have the team to treat the psychiatric illness with people who have intellectual disability. What we don't have, and for a particular reason, is a program specifically designed to address behavioral disorders that are primarily and caused by intellectual disability, because those are long-term treatments. And historically, institutional care and treatment at this level has been detrimental to that population.
So we've heard a lot about New Hampshire Hospital specifically, just more broadly. I think you've also heard a lot of testimony today that describes both our community mental health center and our IDDD system, both of which the department oversees and is charged with having that comprehensive system of care. The way that we currently have everything in statute and rulemaking does not preclude folks from being served by both area agencies and CMHCs. And the section 2 of the bill that specifically calls out that you cannot be determined ineligible for services based on the basis of co-occurring. I think the department would be fine with that, because we feel like that's already how we've been operating. Also feeling that there's been some work done over the last 5 years between the two bureaus of mental health services and BDS to try to facilitate this collaboration. You heard testimony today about trainings for CMHCs and vice versa to make sure that we can have treatment that's adequate. But we're also hearing about a very specific challenge today that we need to get to the bottom of to make sure that we're providing adequate care. But we do just have a concern specifically about the definitional change and that it may have unintended consequences. And so looking to make sure that that's the right move to address the challenge that has been identified.
Senator Abart.
Thank you. And thank you for your testimony. But what I'm hearing through the testimony is two populations, and there's no training. And that to me rings discrimination to me. Mm-hmm. There's two populations. These people are if you have Down syndrome, you're an ordinary person. You've got an issue with a particular biological issue that no fault of yours, but you're to be treated the same as somebody who doesn't. Two populations. That means one's being treated one way, another is not being treated because there's no training. There's no training, and the departments are not, or the facilities are not asking for the money for the services. So I'm glad this bill is brought up, but because there are people that are being left behind, I feel that, and I know you're doing your job. Yes, yes. Dissuade me from the idea that this is not discrimination from just what you just testified on.
So I think what we're here, I don't disagree with you that we're hearing about a very specific challenge and that we're concerned that there's a gap in services. I think the definitional change, we have concerns that it would, because we don't want people to get the service that isn't right for them, right? So if the definition today says primarily, if the person's behaviors are primarily from their developmental disability, they may be better served by that system of care. And so we just want to make sure before we change the definition of mental illness that could have far-reaching implications. And we don't want there to be unintended consequences to a definitional change. Continuing to work on how are our systems serving people and having the conversations about what's the gap in care and do we need additional funding? Do we need additional training? Do we need additional teams? The department absolutely wants to make sure there's comprehensive and equitable care for all people.
If I could also address your request. The challenge right now across the state with mental health and developmental disability services is that the system has a lot of gaps, and some of it has to do with staffing shortages statewide. What I've seen with also people with primary mental illness is that the hospitalizations are prolonged because the level of care they need in the community is not available. I feel like that's at the heart of the problem that's trying to be resolved here. And my concern is that continuing to grease the skids and make it easier to put people involuntarily in the highest level of care in the state is avoiding the real solution.
So I have a suggestion. If, from what, Senator Bradley, did you want to say something? No. Could I ask you three to work with the prime sponsor to see if we can finesse this, at least until we can get to the budget period next year, and see if there's at least a temporary, not fix, but certainly something that will get us through to the next budget. Representative, are you okay with that? Okay. All right. Any other questions from the committee? Seeing none? Thank you. Those are the last speakers. Is there anyone here that would like to speak on House Bill 1028 that was not given the opportunity? We're running way behind, so I'd like to try and move on. So with that, I will close the hearing on House Bill 1028 and will immediately open the hearing on House Bill 1609. Thanks. Maybe. Yes, please.
We're doing 1609?
Yes. If you could just wait a few minutes until Cam is ready.
Yeah.
And I am ready. Thank you. All right. Welcome.
Thank you.
Introduce yourself for the record.
Good morning, Madam Chairman and members of the HHS Committee and the Senate. My name is Jim Murphy. I represent Grafton 12, which is Hanover and Lyme. And I'm introducing today House Bill 1609 as amended. I did give you copies of my testimony, which I will not read. I'll try to get you back on time. No, I can't promise to do that. Not my fault. And also, I would like to introduce an amendment that I have worked with subsequently to the passage of this bill back in February in the House HHS. So the first page of my testimony is really a list of acronyms in the alphabet soup that I have come to work with for the last 40 years, and I still don't fully understand. But the State Office of Rural Health was established in 2008. That is under the Rural Health and Primary Care, which is within DHHS. The primary responsibility of the Rural Health, or the State Office of Rural Health, was to seek, long-term solutions to healthcare access in poor and in underserved areas. Subsequent to that, in 2010, the State Office of Rural Health was charged with two things. One was to collect data, which is very important to understand the primary care workforce within the state, and also to establish the Commission on Primary Care Workforce, of which I'm a proud member for the past 6 months. I was recently asked by the Speaker to join this committee, as I am on HHS and have practiced medicine for about 40 years. Then, about a decade later, OPLC came in. So prior to that, each of our professional boards, I was the Board of Medicine, there was Board of Dentistry, the Board of Pharmacists, et cetera, was then was now under the auspices of OPLC, which now controls about 50 different professional boards and organizations for licensure and basically, obtaining the data necessary. So when I had to re-up every 2 years for my license, you have to, given the demographics of where you practice, how long you're going to practice, your date of birth, et cetera. And the reason being is that they're trying to figure out when you're going to retire, die, or leave the practice, and then you can have somebody else assume that role as you go forward. So this bill has basically three goals in mind. This was passed unanimously out of the House, 19-0, one was absent. First, it was to extend the commission, of which I'm a member, to 2029, so another 5 years. This is to expire, I think it's in the November of this coming fall. Second is to direct the OPLC. Now, remember, OPLC came in 10 years after all these boards were established in their primary care role of gathering data, et cetera. So basically what the OPLC now does is now directed to provide the licensure information that is obtained by them and previously obtained and currently obtained by the various boards within the OPLC. Lastly, it is to add a direct primary care. So what I did, or direct primary care representative. Medicine is changing, from when I first started 4 years ago. It was basically you didn't advertise, you had Blue Cross Blue Shield, you didn't have Anthem, you didn't have Cigna. You just basically, submitted bills, et cetera. Now, when you have the advent of urgent care centers and things like direct primary care, people are not going to their primary care anymore. They are going to direct primary care. They're just, they just need to have their diabetes checked. They have their blood pressure checked, et cetera. They don't require urgent care, so that is really out. What they need is direct primary care. So a member of HHS within the House, Leah Cushman, and I came up with a very brief amendment, and we first established back in February the New England Direct Primary Care Alliance as the member that would be added to the list that I gave you. I think there's about 20 plus members, so it would really not dilute out the membership terribly so. But what we found out subsequent to that amendment in bill passing and then coming over to you all in the Senate was that the alliance is more of a New England alliance, and it does not recognize nurses and nurse practitioners as primary care providers. However, the direct primary care frontier is New Hampshire-based and does recognize nurses in the delivery of primary care. So what we tried, I would propose to do is to introduce Bill 1609 to you all for your consideration, and then to introduce the amendment to that bill. I can do it, or a member of your committee can do it, but in changing basically the name from New England Direct Primary Care Alliance to the Direct Primary Care Frontier. And what that really does, it basically allows primary care to be more centralized within New Hampshire, and also to recognize nurses and nurse practitioners as part of the delivery care model in primary care going forward. So again, I'll finish with that and ask if there's any questions that you might have of me or of the commission. I believe there are representatives behind me. But the goal is to extend the commission for 5 years. It is to basically obtain the data that is collected by OPLC, and then to add the Frontier Direct Primary Care as a member of the commission, so that model of medicine can be represented on the commission itself. Thank you.
Thank you,
Any
Representative.
questions?
Any questions from the committee? Cam, how would we we just, the amendment, we would just introduce it when we're ready to exec the bill.
So during executive session, a senator will just move the amendment. You'll just move amendment
And that's what we'll
1416H.
Right, we had asked prior to that, and Kim mentioned that, I could either introduce it, or when you have your exec of the bill, you could then introduce the amendment, and I should mention that Representative Cushman is on the other side of the aisle, and we worked together to basically come up with a plan to have direct primary care as a representative, but felt it was important to have it, be based out of New Hampshire and recognize nurses as given primary care.
Thank you, Representative. What we'll probably do is when we exec it, one of us will introduce it and
Thank you.
put it through. Any other questions? Seeing none. Thank you.
Thank you.
Next, I have Danielle Hernandez and John Williams.
Chairman Birdsell, and members of the Senate Health and Human Services Committee. For the record, I'm John Williams, the Director of Legislative Affairs, and the fact that I'm not seated is an indication that this will be fairly brief testimony. Just wanted to also identify for the record is with me.
Danielle Hernandez. I'm the administrator of the Health Professions Data Center, or HPDC, and the Office of Rural Health and Primary Care at the Division of Public Health Services.
And Ms. Hernandez does an incredible amount of work. I just want to draw your attention specifically on Section 3 of the bill, starting on lines 13 through lines 18. We had worked with the Office of Professional Licensure and Certification. They're a great group of people to work with under the direction of Executive Director Lindsay Courtney, as well as working with Attorney Douglas Osterhout. And so what we're doing here is honoring their request for reciprocal authority. We have, as you'll see from the citation on the last line under RSA 126A:5, Roman 18A, that we already have the authority to request and receive this information, but the Office of Professional Licensure needs within their enabling legislation reciprocal authority to do the same. So that's essentially one big piece of this. We want to thank the bill's sponsor, had bipartisan support. I know Senator Prentice is also a co-sponsor on this bill, so thank you. And with that, I would turn it over to Ms. Hernandez. And I think there was a word I was supposed to say other than thank you very much for our testimony, which is the word emails.
Do you want me to skip forward to the email portion? Okay, so the data fields that OPLC collects and maintains and that we ask for to do our work in workforce assessment, provider surveying, shortage designation, are all public besides one field that's a non-public field, and that's the provider email. And that is used for non-compliance follow-up to increase response rates. So the way that providers verify compliance is through attestation on the renewal application under the Office of Professional Licensure and Certification. Even though the survey has now been implemented as a requirement for over 3 years, we still see a non-response rate between 15 and 25%. When the Health Professions Data Center sends out that email reminder, it drops down to between 1 and 4%. So without our hand in the compliance effort, the final list sent to OPLC's enforcement division would be significantly higher. We'd risk losing reliable representative data that's absolutely critical for shortage designation, again, workforce assessment, everything we do, and can only come from high response rates. And I should add that we were receiving these fields until August of last year when OPLC determined that they would need the statutory authority to provide this data.
Any questions from the committee? Seeing none. Thank you.
Thank you.
Is there anyone here that would like to speak on HB 1609 but was not given the opportunity? With that, I will close the hearing. And
we're going to open up the hearing to HB 1615 and hear from the prime sponsor. And if we could keep it to, we've got a lot more bills to hear, so if we can get be succinct in our testimony, that would be greatly helpful. So Rep. Eric?
Hi, so I'm Representative Eric Gallagher from representing Merrimack County District 20, which is Concord Ward 6, here to introduce House Bill 1615 relative to the Autism Registry as amended. First, to understand how it came into its amended state, I'd like to start with how I originally filed it. I won't go over the full text of how I filed it. So basically what happened is just from being part of the neurodiversity community, people discuss various policies related to it occasionally online. And through one of those discussions, I found out that New Hampshire has an autism registry, that this exists in the first place, which kind of took me by surprise. I didn't know that. So my first reaction to that was just, I wonder, does this include personally identifiable information? Is this consistent with our state constitution's guarantee of privacy? So my first draft of that at this bill was just to try to address those questions, to try to reduce the amount of personally identifiable information in it, and improve the privacy protections in it. As the process of this bill going through committees went on, though, or at the previous hearing, we heard that a number of people actually would prefer a full repeal of the registry, and which I kind of had concerns about at first, but through the course of the hearing and from hearing the testimony from DHHS that apparently they would be okay with a full repeal themselves, that convinced me to support a full repeal as well. So that's the other DHHS committee amended the bill to read as it does in its current form. Personally, if I had been the one to write the amendment, I wouldn't have used such harsh language as destroy, but I guess that is kind of what ending it would mean, would be to destroy the records. So in that case, I support it. Since this is running behind and there's other people to testify, I'll close it here and take questions now.
Any questions from the committee? Seeing none. Thank you, Representative.
Yep, thanks.
Representative Katab. Welcome.
Good morning. Thank you for having me. For the record, my name is Representative Caitlin Kutab. I just wanted to briefly speak to this bill. So this was amended in the House just to do a full repeal of the state autism registry. It was created several years ago as a way of analyzing the data. However, it really hasn't been used for, I couldn't find one thing that it was actually being used for that was useful, I guess. They're not doing anything with the data. And the data already exists in another form, like through the New Hampshire Department of Education statewide disability consensus. You can see the number with autism throughout all the years, so you can kind of already get the data. And I'm not sure if you compare the numbers that it's actually that accurate anyway, that many providers are actually turning in the information that somebody was diagnosed with it. If you look between 2021 and 2022, the number that were diagnosed was 160, but then the number that ended up with the DOE that increased was 265. So was that just 105 kids that just didn't have IEPs before, or was it just that the providers didn't turn in the information? The information in the database, it does contain personally identifiable information of the children. It does have the last 4 digits of their social security number, their date of birth, as well as their initials and their town. And if you look in a district like ours in Wyndham, in the town report, it'll list all of the kids that were born and their parents and whatnot. So you could easily figure out by the initials and knowing the town, like who this child was. So parents just, they didn't even know that their children were in this database, let alone consent to it. It had been talked about, oh, well, maybe we'll make it an opt-in registry, which really doesn't make sense because how good is the data if you only have half the data? So where we're not doing anything with the data, it doesn't make sense to keep it. And we should fully repeal it. A lot of parents want their child information removed from it. So I hope you'll support it. Happy to take any questions.
Thank you. Any questions from, and where's your daughter?
She took a field trip with Marissa. She made a friend.
Any questions from the committee? Seeing none. Thank you.
Thanks so much.
John?
Chairman Birdsall, members of the Senate Health Human Services Committee. For the record, John Williams, Legislative Director for Health and Human Services. And this was a bill that we did testify in at the House. It was interesting that at the hearing, this bill was actually established back, or rather the registry was established back in 2006 under House Bill 1706. Coincidentally, former Representative John DeJoy was in the audience, and he was actually the prime sponsor of that bill. And in working with him, he agreed that the purpose originally identified for the registry is no longer. And so the information that is readily attainable through the Department of Education around autism is much more robust than the limited information. I think the speakers you heard before, the representatives did a really good job outlining the reasons why we are fine with repealing this particular registry. I say that with a very cautionary note because we have other registries that are extremely important to the department, including cancer registry, immunization. So this is not reflecting, on anything on those particular registries. But in this particular case, I think it was very thoughtful that they identified the repeal of not only the underlying registry, but also rulemaking authority, and they gave the department guidance on what to do with the data very thoughtfully, even though the word destroyed might be a little bit harsh, but it actually gives us very clear guidance in terms of what the expectations are of the legislature. So with that, we are fine with this legislation, and that concludes my testimony. Open for questions.
Thank you, John. Any questions from the committee? Seeing none.
Thank you.
Thank you. Alex? How'd it go?
Good morning. Thank you, Madam Chair and members of the committee. Just for the record, Alex Katrubis, I'm here to represent the area agencies. We don't have a position on the bill. We are neutral. I didn't testify in the House, but the area agencies did ask me to look into the issue once the bill was amended, as you heard in the House, and passed on to you here in the Senate. So I reached out to the Department of Education, and as you heard, and I agree with the previous testimony, I did ask them, and you can see in the email that you're being handed out right now, just confirming that they have data on autism, how they obtain that data, which is basically from the local school districts. And if we do pass this bill, would it have any impact on the work that they're doing at the Department of Ed? And as you can see in the email, that they don't use this DHHS controlled registry. They're getting the data directly from the school districts, using information from IEPs. So I don't think there's any harm in going forward with this legislation. The other thing I wanted to just quickly point out is I did reach out to a former state employee who was the head of developmental services at DHHS at the time that this registry was created. And he did get back to me, and just real quick, he says that we created the autism registry to have another source of information to track what was happening with autism. This was at a time when there was a new and increased focus on incidences of autism. It used to give us supplemental information, especially regarding the ages before school years. We were interested in detecting any significant increases in the data before the children get to school age. We wanted to be able to flag that type of change to all parties concerned, including the legislature, to support any requests we might be making for additional funds. We also wanted to have another source of data in case there were problems or discontinuance with the Department of Education reports. So, as long as the Department of Ed continues to do the work that they've been doing, I believe the report comes out every December. Again, we don't see any issue with moving forward with Representative Gallagher's bill.
Thank you, Alex. Any questions from the committee? Seeing none.
Thank you.
That is our last speaker. Is there anyone that would like to speak on 1615 but was not given the opportunity? With that, I will close the hearing. And when Cam is ready. All right. I will open the hearing on House Bill 1056 and welcome the prime sponsor, Ross, Representative Berry. Welcome.
Awesome. Okay. Thanks for having me. My name is Representative Ross Berry. I represent Manchester's Ward 689, fighting South End. I'm here to introduce House Bill 1056 as amended. As amended, it's basically an entirely different bill than what was originally proposed, which is fine. I'm the chair of the Special Committee on Childcare in the House, and one of the things that was brought to our attention was that we defined basically childcare is obviously governed by a mix of laws and rules, and one of the problems we discovered was the statutory limit for how long a child can be in a child care center was limited by law, so DHHS was not able to amend this. So what we have done is we've allowed for basically the extended hours of over 13 hours in certain situations that were brought to our attentions, primarily the number one being work. So an easy one is nurses at Chad and Dartmouth work a 12-hour shift. Right, so 13-hour limit is actually a problem for them if their child care center is not literally on their way to work. A lot of them live in Vermont. The other thing that was brought to our attention is those who are deployed away for the weekend for military reserves, National Army Guard, that sort of thing. So we basically built in this exception. One of the things that is not in the bill but is in the House intent when we passed it was this does include three-day weekend deployments. Our interpretation of the way it was written was if they are deployed for a short period of time for reserve training or something like that, we consider that a weekend basically regardless of the length. So it came out of the committee on a 10-0 vote and it passed in the House on a consent calendar.
Thank you, Representative. Any questions from the committee? Seeing none? Thank you. Keep this up. We might actually be on time. DHHS is here in case they want any questions. We want any questions answered? Do we?
Nope.
Okay.
Oh, I would love to hear from them.
Okay. DHHS, come on down. Melissa Clement, welcome.
Good morning, members of the committee, and thank you. I'm Melissa Clement. I am the Chief of the Child Care Licensing Unit for the Department of Health and Human Services, and I'm here to answer any questions you have, and we don't have any opposition. If that was, yeah.
Thank you, Madam Chair, and thanks for coming up. That was going to be my question, your
Yeah.
thoughts on this. You were involved, of course,
Yes.
making sure our small businesses stay afloat
Mhm.
is critical, and also making sure just kiddos are safe. And so
Yes,
do you
absolutely.
think that this bill strikes that balance?
Absolutely, yes. I think it was needed so that we could change our childcare licensing rules so that we could better help families and programs. So,
Thank you.
thank you.
Thank you.
Anyone here that would like to speak on 1056 was not given the opportunity? With that, I will close the hearing.
But when we go to exec, I can just like. I mean, I like hard copies.
Okay, I will now open the hearing on House Bill 1407 and welcome the prime sponsor, Representative Berry.
Okay, long time no see. Representative Ross Berry, I represent Manchester's Ward 6, 8, and 9, the Fountain South End. I'm here to introduce House Bill 1407 as amended. In my opinion, this is probably the seminal work of the Special Committee on Childcare. When you're looking at childcare, I can talk about this bill ad nauseum, so if I start rambling on, just hit the gavel. When you're looking at childcare, you're basically looking at 4 key aspects: access, affordability, quality, and most importantly, safety. So the problem is access and affordability are often in direct competition with quality and safety, and there's always a trade-off. And when addressing the childcare crisis in New Hampshire, it is most acutely pronounced with infant and toddler care. And the reason it is most infinitely pronounced there is because those have the lowest teacher to student ratio. So a 6 weeks to 1 year is a 4-to-1 a 4-to-1 student to teacher ratio. So average cost of infant care in New Hampshire is $15,000 a year. It is the most expensive childcare that you will pay for as a parent because it has the lowest teacher to student ratio, right? So to give you kind of an idea, when you get up into the higher age groups, when you have 10-to-1, 12-to-1 student ratios, the cost to carry those 12 kids is the same as the cost to carry those 4 infants, right? So you have the same amount of cost being diffused over fewer children. So that leads to a couple of things. Number one of which, very high prices for infant care. Number two, child care centers do not want to engage in the space because it is virtually impossible to profit make off of it. For most centers, the reason they have an infant and toddler program is to feed into the higher age groups where they can finance the rest of the center. So what ends up happening is the older kids end up financially subsidizing the younger kids, and it's all because of teacher-student ratios, right? So your average business, your cost of labor is anywhere between 20 to 30%. In childcare, your cost of labor is going to be anywhere between 70 to 85%. So it's entirely a labor-based business. It is, in fact, a service business. So when you get into that, you have to address the underlying issue. The underlying issue is you have this crisis created by the fact that you can't get enough kids into a room because the ratios inherently limit them. That doesn't mean the ratios are evil. It doesn't mean that they're bad. They exist for a reason. I've worked in the infant room myself. As you guys know, I own a child care center. I've worked in the infant room myself. It is the worst room to work in. I'll tell you that right now. I do not, I'll take the older kids any day of the week. But it's a tough, I know they're so cute until they're messy and then they're not. But the problem is we don't have access, right? So there's not enough access. So the number one way to increase supply is to crack this ratio open a little bit. So originally I thought to the idea, all right, we can go to 5 to 1. And not a lot, there are states that have 5 to 1 ratios, but ultimately, thinking about it, I tried to immediately go to the compromise position. So we're not going from a 4 to 1 ratio, we're not going from 4 to 1 to 5 to 1. What we're doing is kind of adopting what Massachusetts does. Massachusetts allows for an extra child to come in if there's a second teacher. So the ratio would go from 4 to 1 to then 9 to 2, right? So 4 was 4 to 1, 8 to 2. Now it's 4 to 1, 9 to 2. So it's a much staggered down increase in terms of the ratio. But you're actually expanding out. If you think about it, 12.5% access to infant and child care. We carry that ratio across the different age groups. They're currently enshrined in rules. And then to make it even more, I guess, palatable, because whenever you start touching these child care ratios, there's obviously understandable pushback from people who are concerned about quality and safety. So what it does is it creates a 2-year pilot program under DHHS, in which DHHS will produce 2 reports, one after 1 year and one after 2 years, about how many centers have adopted this, what they're seeing on it. It also gives DHHS the discretion to deny an applicant to go to this increased ratio if there's like repeated safety concerns in the center, right? So a center that has had repeated safety violations, DHHS can look at that and say, hey, look, you can't handle 4 to 1. Why would we let you go to 9 to 2? And they have that discretion. And then in 2 years, this body can take it up again and look at it and see, okay, maybe a 9-to-2 ratio is not so bad. I'm happy to answer questions on this. I do believe, like, if you want what is a silver bullet to try and fix some of the childcare crisis in the state, this is your silver bullet. It does take deliberation. We did talk about it extensively in the childcare committee. There are pros and there are cons to it. I won't lie and say there's not a downside. Of course, there's a downside to it. But the reality is a child is safer in a childcare center than they are at home. It's just statistically proven. Not to mention that children develop better around other children that are older than them. So if you want to get mom or dad back to work, they have to have a place to send their kid that's affordable. You want to lower the cost of childcare, you need to put more children in without increasing costs. So this is a way to increase revenue without dramatically increasing costs. No center is forced to do this. If they don't want to do this, they don't have to apply. They can maintain a lower ratio. To give you an example of the differential between ratios, Massachusetts has a 3 to 1 infant rate to child ratio. We have a 4 to 1. The cost of child care for an infant in Massachusetts is $5,000 a year more than in New Hampshire. What has this caused? This has caused some Massachusetts parents to bring their kids up to New Hampshire because they can't find child care in Massachusetts. So we know that these ratios are directly related to cost. And if you want to, I guess what I'm saying is if you want to lower costs, increase accessibility, you have to look at the ratios, and this is a pilot program to begin looking at those ratios.
Thank you, Representative. Any questions from the committee?
Awesome.
Thank you.
So this is simple. Thank you, Representative Berry. So it's a pilot. You can enter into it if you want to do it. So it's not required to test this out.
Mm-hmm.
Like, dip your toe in the water. Did you have any opposition?
So yes and no. We had opposition to people who didn't understand it. Okay. So when it was initially rolled out, all they heard was increased ratios. So they thought we were going from 4 to 1 to 5 to 1, right? And I knew that'd be a non-starter. So when you actually started kind of explaining to him, the opposition kind of withered away. I imagine there's probably some people who are still opposed. Largely what I find is the opposition comes from groups that are grant-driven or nonprofit and have other funding sources. But the reality is you won't find much opposition. I don't believe we had a single child care center wrote in opposition to it. The core kind of problem you run into is just people having a knee-jerk reaction being no. I will point out, no center is required to maintain the highest ratio possible. If you wanted to run a childcare center that had a 1-to-1 ratio, that's your business. We don't mandate that it's 4-to-1. We just say you can't go higher than 4-to-1. And I think that was something that was repeatedly brought up. Something else that was brought up was teacher burnout. So I kind of did my own little survey on this. I asked my teachers, I said, hey, how would you feel if I brought in one extra kid into the infant room? And they're like, well, I don't know about that. I said, well, how would you feel if I gave you a $2 an hour raise? Because now I can do that. And they went, well, yeah, absolutely, sure. So, if you want to pay your teachers more, you have to have more revenue in the room. The way you get more revenue in the room is that you increase the number of children in the room. So that was kind of the biggest opposition, I would say. But it largely went away when people realized, like, we're not talking about 4 to 5, we're talking about 4 to basically 4.5.
Okay. So in healthcare, we start talking about patient ratios. This is what got I'm like, wait a minute, it can be a very neat, combative conversation. So that's why it's always good to know, like, where the other potholes are. Thank you.
Yeah, the bill did pass out as a 10-0 on consent calendar. So we did try to bring in, because it was originally just an increase, and then the opposition said, can we make it a pilot program? We said absolutely. So that kind of assuaged their just no, was, all right, well, let's see. And this is a great way to let's see. My gut is that it'll be adopted by, I would probably say 30% of the centers will probably pick this up. They have to have the space to do it, right? So they can't, there is a cap. It's basically 40 square foot per child, excuse me. So they have to have the space. This doesn't waive other requirements. They still have to have the space. And the thing that I don't like about this bill is that because it's with that second teacher, you are kind of picking winners and losers. If your center doesn't have the capacity, the physical capacity to handle that, you obviously can't apply, right? If your room cannot handle 9 children in one room, you cannot have 9 children in one room, regardless of what the ratio is. And that's the way it is now, right? If you have a ratio of a room that's 8-to-1, but it can only hold 7 kids, guess what? You can only have 7 kids. So DHHS goes through, they measure all of the rooms, they have nice little laser finders, and they do the math, and they tell you how many kids can be in each room.
Yeah, so that, thank you, Madam Chair, and thanks for taking my question. That sort of sparked another sort of question about what you're and I appreciate you putting that right out there, that sort of balance that we're all looking for, right? But the idea of picking winners and losers. So is there a concern that we're going to put the little guys out of business?
Well, it's possible. You wouldn't put them out of business because there's no childcare center in the state has trouble finding parents right now. Hopefully, as a business owner, I love that. As an elected official, I hope we change that. So no, you're not going to put anybody out of business. What you will do is you will enable the places that have the capacity to do this. What I'm hoping is we'll actually encourage some room shifting. So where instead of childcare centers looking at specifically, and once again, this is for all ages, but the problem is with infant and toddler care. What I'm hoping is childcare centers will start looking at that infant and toddler care as not a loss leader or a break even, but a potential to actually go and do it because it will make positive revenue for the center. And that will increase the, obviously, accessibility, and then we'll hopefully start seeing this problem begin to be abated. Thank you.
Hello again, for the record, Melissa Clement, Chief of the Child Care Licensing Unit at the Department of Health and Human Services, and happy to answer any questions, and we don't have opposition to the bill. I'm happy to answer questions.
Thank you, Madam Chair. So same question, there's an important balance of making sure we're, keeping childcare affordable, while also keeping kiddos safe. We want to support our small businesses, and that's what most of these folks are, small businesses. So do you think this strikes the appropriate balance? Do you have any concerns about this sort of really being problematic for our smaller centers?
As Representative Berry mentioned, we have some programs that were for it, some programs that were concerned about it, but it is voluntary. So those programs who want to move forward can. We have in our rules already a waiver process that does say we'll grant waivers based on the health and safety of children, provided there's no other prohibitions based on other state agencies or those type of concerns. So we are very practiced in looking at a waiver request and determining whether or not the program will be able to safely implement the change that they are requesting. This waiver also will require approval of the local fire inspector because there are, I'm sorry, the waiver will require approval by the local fire inspector due to ratios being in the life safety codes. And so we have already a agreement with the state fire marshal's office with the ratios that we have in our rules. So we would have to get permission that way as well. We think we're well positioned to monitor this program, and to do that, it's going to be up to the program, and we can definitely see a need because we are losing infant and toddler slots. So.
Any other questions from the committee? Seeing none. Thank you.
Okay, thank you very much.
Motion to move into executive.
Hold on, slow down. Is there anyone here that would like to speak on House Bill 1407 but was not given the opportunity? With that, I will close the hearing on House Bill 1407 and will entertain a motion.
Motion to move into executive.
All those in favor of moving into exec, say aye. Aye. Opposed? Okay,
I'd like to move an amendment, your amendment?
well, we need to pass the bill.
Oh, you do? Do you have to move it first? Pass it?
We have to ought to pass on the bill.
Oh,
I'll move on to pass on House Bill 322.
I'll second that.
Say that again? House Bill what?
322. It's the one relative to establishing the committee to.
Yep.
All right, and I will move the amendment
1371.
1371.
I'll second.
Any discussion?
Just briefly, Madam Chair, I mean, of course, I think, finance will have a rigorous conversation about this, but I think policy-wise, it makes a lot of sense.
And I just want to say thank you to the committee for listening. I know this is, I have visited the facility when both wings were down, and it's, they have been asked to open the facility from some of the other players in the arena, so he's been doing everything that he should be doing to try and keep people working, to take care of our elderly. So I just want to thank everyone for entertaining this. Where am I?
Motion
Sure.
to move as amended.
I think you had a second.
Kim? We had a second.
Yep, so amendment 1371S has been moved and seconded, ready to vote on it.
All those in favor of 1371S, say aye.
Aye.
Opposed? I move on to pass on House Bill 322 as amended. DPA.
Second.
Any discussion? All those in favor of amended House Bill 322, say aye.
Aye.
Opposed? Do we want consent or do you want?
Consent.
Yeah, second.
Okay, all those in favor of consent, say aye.
Aye.
Opposed? All right.
You're gonna take it out?
Oh, I'll take it out. Any other discussion on any bills before we move on to consent? Nope. All right, well.
Motion to move out of exec.
Second.
All those in favor of moving out of exec, say aye.
Aye.
Opposed? Everybody be safe
Thank you.
in the snowstorm if we get it.
Take my rocket
Everyone
ship
check the
and head
generator?
north.
I need to fill my tub up with water.
Really?